Yeah, and based upon all those things, we need to decide in which category, where do you going to manage, whether the patient deserves intensive protocol. All those things we need to assess when you're going to manage a patient with inflammatory bowel disease. This is basic, simple classification that we are not supposed to forget about Montreal's. So this is based upon your E1, E2, and E3. Montreal's is distribution of your UC. So anything which is predominantly involving the rectosigmoid region is predominantly rectosigmoid or proctitis, and next to that, once the patient is going to have this area of involvement will be more common because around 30 to 60% of the population will be presenting to this kind of presentation. And left-sided colitis, if the patient is going to involvement, it is predominantly to the left side, which is distal to the splenic flexure. That is left-sided colitis. Once the patient is going to have left-sided colitis,
sorry. Sir, ఇప్పుడు మీటింగ్ లో తర్వాత మళ్ళీ sorry sir, important.
Okay, no problem. So once a patient is going to have left-sided presentation, there will be tenesmus, bloody diarrhea, or this is the characteristic presentation. But once the patient is going to have extensive, which means the involvement of transverse as well as your right-sided colon, once it's going for extensive colitis, the predominant symptom, your constitution symptoms like fever, weight loss, anemia, recurrent, all those symptoms we should not forget when you're going to manage a patient with extensive colitis. So basic definition will not change where we are, so we need to remember the basic definition. What do you mean by remission? What do you mean by response? What do you mean by relapse? What do you mean by frequent relapse? What do you mean by infrequent and frequent, continuous, steroid refractory and steroid dependent? These are all the basic definition we should not forget. Simply I would like to make things, so remission means once you're going to start the medication, the patient shows evidence of response by your clinical resolution of symptoms and your endoscopy response should be reasonably well. And stool frequency as per your stool weights, once the patient is going to present to us more than 5 to 6 episodes of stool, that stool frequency if it is going to come down, that shows evidence of remission has been well. Step up and step down of process, we are well known based upon mild to moderate and moderate to severe intensity when you are going to manage a patient with ulcerative colitis. So based upon that, so what are the medication, whether the patient is going to respond or once the patient is going to switch on to the next medication, those are all the questionable issues still we are facing day in and day out when you are going to manage a patient with IBD. And use of pain medication, sometimes there are multiple regimens, homeopathy, alternative regimens. So if the patient is going to have any pain medications, so there is high possibility once the patient is going for NSAID, which will also worsen your clinical scenario of IBD. And lifestyle, if you are having stress, environmental factors, always there is no single etiological factor being identified. And one simple important thing right now, based upon your immune dysregulation, that's what's very common, and microbiome dysfunction. So based upon your PAMP and DAMP activation, once your microbiome, if it is going to get dysregulated, there is high possibility. Nice. Welcome, sir. So once your microbiome is going to get dysregulated, as we see now, the microbiota system is being considered as a separate entity in managing. So it's being, as you all know, inflammatory bowel disease, when you're going to look into that, it's broadly categorized into two major entities. One is by ulcerative colitis, and next to that by Crohn's. And ulcerative colitis, the predominant area of involvement will be restricted to your lower bowel, and it grows right from mouth to anus. It can involve any area, and predominantly we can able to identify non-case-eating granulomas in Crohn's. And if you're going to see, there are various extra GA manifestations in Crohn's, and when compared to ulcerative colitis, also can present both the areas to a different area of approach, a different area of management. And my current perspective, when you're going to talk about flare, so any patient who presents to us, even if after induction of remission in the management of inflammatory bowel, so once the patient is going to develop a flare, how are you going to recognize the symptom, how are you going to recognize the complications, how are you going to manage a patient with this kind of scenario? There are various huge tough clinical aspects of that. Even when you're going to learn this inflammatory bowel disease day in and day out, we'll be always having tough schedules, and even our clinical approach will always be healing, high yielding, when you're going to manage a patient with that. So the basic introduction about what do you mean by flare. So anything which is going to worsen, if the patient is going to have most common presentation in IBD, the patient is going to have evidence of proctitis or left-sided colitis, or when the patient is going to present with extensive colitis, etc. So the most common presentation, if it is going to be in rectum, the common symptoms will be your tenesmus. It's a painful defecation. What's going to happen? Sometimes rectal bleed, diarrhea, or increased frequency, urgency. All those things will be going to dictate your flare-up. So flare is a period of sustained and lingering GI symptoms, which described earlier, that alternates with remission in clinical pattern, in a cyclical pattern. So these are all the various factors which is going to predispose, which is going to worsen your flare. So if you have the patient is not going to take any proper medications, the adherence if the patient is not going to take steroid. And in this paper, so the steroid responding, I mean steroid dependency based upon your unavoidable and avoidable status, your avoidable steroid dependency will be slightly lower and unavoidable steroid dependency will be slightly higher, and non-steroid dependent will be occupying a huge list of patients. So this is the area we are not supposed to forget. So this is the area is one of the most of the complications being relied upon. So possible steps to curb your steroid excess. So monitor, look for second line of molecule and access to specialist gastroenterology approach services, and we need to inculcate the habit of measuring your steroid dependency as a part of ongoing quality improvement program. So this is the basic outline about final line. So start with your flare of steroid, first flare, once a patient requiring oral corticosteroids, so start with budesonide, 0.2 milligrams.